We have to assess what are their cultural needs, what are their financial resources, what kind of environment are they in. They might live at the top of a mountain somewhere, and what do you want in case you have a heart attack at the top of the mountain? What are we going to do, right? And then, of course, we have to have everybody in agreement. So advanced care planning is going to provide that. So we have 2 documents we can do. We can assess one document will make sure, will identify someone as the power of attorney, meaning that they are going to make all decisions for the patient or client if they have a terminal outcome, if they have a cardiac arrest, for instance, or they get admitted to the hospital. Okay, so you can see about 75% of our nation's money is spent on the last 30 days of our patients' lives. We spent about $500 billion, about 300,000 on average is spent the last 12 hours, or that's caring for a patient who has a chronic disease that is terminal. So that also the amount of money we spent is immense. Again, money's not everything, but it can not buy happiness, but it can buy more ADLs, it can buy more time, right? So we want to make sure we are knowing what to do in the case of emergency and also orders to carry out in that emergency. Okay, so this is advanced care planning. So they are identifying chronic illnesses, saying, hey, you have this chronic illness, these are the other things that are going on. We want to clarify expectations, make sure they know what to expect. They know the costs and side effects of what they're getting into, because oftentimes, a provider or a blue-eyed, new med student is going to prescribe the best therapy known. But does that best therapy have side effects? Is that best therapy even affordable? So we have to decide what the side effects are, the costs, what they want, right, out of their disease process, right? We have to maximize palliative care at every opportunity to say, hey, you're having a lot of pain, let's fix your pain. You're having a lot of anxiety, let's fix your anxiety. A lot of depression, a lot of discomfort, your cognition is not that great, and maybe we might need to consider doing other goals of care discussions. Okay, so what else? So taking steps are to plan to plan for the unexpected, right? So sometimes people don't want to bring this up because they say, they might say the wrong thing, or they might say, or the patient, again, is waiting for the provider to bring it up, and the provider is waiting for the patient to bring it up, right? So, and 1/3 of patients, and then also the provider might not bring it up because they're assuming things about the patient. They're assuming things about the patient's culture. They're assuming things about the patient's religion, that they are this religion never gives up on life, so I'm not going to bring it up at all. So we have to assess their cultural piece. There's also times, like I don't have time to discuss that. It's going to take like 10, 20 minutes to discuss everything. It takes like 3 to 5 minutes. It doesn't take long. I can tell you in the ICU, we have discussions like in 2 to 3 minutes. Like we have to discuss what's going on. They're decompensating. This is what we need to do. And we have to have the discussion right away. And we can't have other discussions that have been like 60 minutes to 2 hours. We're discussing all the things that are going on. Okay. There's a lot of discomfort. It's not a part of routine education, especially at the provider level, but that's why we're educating you now, so that you can assess what they do and don't want. I can't tell you the number of times where it was the nurse that gathered all the information from the family and the patient about what the patient does and doesn't want, right? That is the job of the nurse as well, is to assess, hey, you have this disease, what do you like to do? What do you want to do? And you're on this medication. What do you think about this? Are you having a lot of anxiety? Are you having a lot of pain? Okay, so tips is to make sure for patients especially is to talk to the patient's provider, talk these things and get these things in writing. So these things in writing are our advanced directives and our POLSTs, right? So we'll discuss those guys in the next slide. What are the differences between a POLST, a physician's order for life-sustaining treatment, or an advanced directive, which is going to outline who makes decisions for them. Okay, so you want to be able to talk about these things. We want to be able to write it down, and we want to be sure that everybody is on board, because you don't want it just to be between dad and the oldest child, and now the other 2 children come in and say, what are you guys doing? What's going on? I never agreed to this. So we want to make sure that everybody is involved. Okay, so advanced directives are, if they're not in place, we provide the standard care. The standard care is do everything, meaning that we do the intubation, we do central line placement, we do all the things to resuscitate somebody. But we want to make sure we have that, if the patient doesn't want all those things, we got to have that in writing. Otherwise, how are you going to dig up a legal document, right? Do you know where your birth certificate is right now? You know where it is. Can you go grab it? Can you provide a copy to the hospital when the patient, in the 2 minutes when the patient needs to be intubated? No. So you want to make sure that the family knows where it's at, but also what it contained, and also the patient knows if they're alert enough to make the decision. Sometimes they're not alert, and that's kind of the purpose of this document, right? So it's an advance directive or a living will. It outlines who the healthcare power of attorney is, who is the one that's going to make decisions for them when they can't on their own. Okay, so it can have general treatment wishes in there. It can also tell you what to do after they die. I want to be cremated. I want this. I want that. It can outline many things, but that's the idea behind a advance directive. It's a legal document. All adults should get one. They even recommend, is from California's website, age 18, get your advance directive. I don't have an advance directive. So, I mean, all of you should have an advance directive right now. You should have something in writing to say what to do if I get into a car accident on the way home. What do I want, right? Who's going to make decisions for me? Is it going to be a wife, a daughter, an aunt, a cousin? Who is going to make decisions? And we'll talk about that, about if that isn't determined, there's a hierarchy in California about who makes the decision for you. Okay, and then we have POLSTs. POLSTs again stand for what? A physician's order for life-sustaining treatment. So it's usually on a big bright pink paper. We'll have an example in the next slide. And a POLST is going to outline, it's going to be right there when someone gets picked up from the ambulance. They can pull that out and say, this is what I want, right? And that's going to tell you, hey, they don't want to be put on a ventilator, or they don't want CPR to be done, or they don't want this to be done. All right, and we'll talk about the elements of that as well. And those who should get one done are those that are ill. They're seriously, they have COPD, that's the end stage. They're at CHF, that's the end stage. They should have a POLST, filled out so they know what to do, right? And it's a physician's order, so it's usually discussed between the physician and the patient. Nurse practitioners can as well. Okay, so why would you have an advance directive? To say who you want to make medical decisions for you. Communicate your medical wishes, your values, your post-death wishes as far as cremation or burial. Versus a POLST, it just communicates to emergency personnel. It tells the EMT, it tells the paramedic, the fireman what to do when they go to your house for a 911 call, or someone does a wellness check on you because you haven't answered the door in 3 to 5 days. They find you face down, barely breathing. What do you do, right? So we're going to make sure that document is nearby so they can see what is going to happen or not happen. All right, who fills out a advance directive? That's going to be the individual when they're alert, age 18 or greater. They're going to fill it out and they're going to have a witness, right? And usually the witness cannot be the person they're going to assign it to, because that could be coercion, right? It's like, yeah, sign this, sign right here, do this, give all the money to me. So you can't, that's not okay. It needs to be someone that's unrelated to them. And usually that doesn't happen, so we just grab a notary. A notary job is to make sure the signature is theirs and they weren't under distress. Okay, whereas a POLST is just between the provider and the patient. And of course, we want to encourage the family is nearby so they understand what to do, what will happen when the patient has a event where they can't speak for themselves, or when they have a medical emergency, right? So healthcare surrogate. So that's someone that makes decisions for them, all right? So a healthcare surrogate is like a healthcare power of attorney. That's the one that the advance directive is going to describe. A POLST is just orders. They just tell you what to do, not to do. Okay, and then we have our emergency personnel going to act on this. Is emergency personnel like, wait, where's your advance directive? Okay, file cabinet, bottom drawer, last one to the left. They're going there. It's like, okay, it says here that you want to be buried at Thousand Oaks Crematorium. Is that correct? That's not going to be there in a medical emergency. Whereas the POLST is easily visible, and they're going to show you. It's going to tell us what the emergency personnel what to do. Okay, so an advance directive, again, it's providing information on end of life, autopsy. These are all the pages here. Kind of highlighted the things I've already talked about, is outlining a healthcare power of attorney. It's letting you know that this person is legally required to make decisions for you. If someone else comes in, a sister from France comes in and says, no, I want them to be full support, and I want them to be cremated, not buried. It's like, no, I'm the one that was appointed when they weren't in distress, and they were of sound mind. This is what we are going to do, right? It tells you that your who can witness this, and in that event, it tells you, this person is going to be the person to make decisions for me. It can outline like what kind of, what CPR they want, if they want to be intubated for 2 days or 3 days, tells you if they want a feeding tube or not. There is some overlap here between our pulsed, which is bright pink in California. So it can outline some of those things as well. But as far as the witnesses are concerned, who can be the witness? It just can't be the person that you're describing, right? The HPOA, the healthcare surrogate. It also can't be someone who might benefit financially. That's someone, and it also cannot be the nurse that is taking care of them. That's going to be a little iffy. And so it can be a nurse in the family. That's fine, but it can't be the nurse that's taking care of them. So here's the pulse. Here it's nice and bright pink like this. It has different sections here. Okay. These different sections outline what do I do for CPR. So this is instructions to who? To emergency personnel. It's telling them what to do. Do you want them to do CPR or not? So it's yes or no. So if it's yes, the first box gets checked, right? And we skip over to the third box there, because the second box says, if you don't want CPR, what do you want done? Do you want to be put on a ventilator? Do you want to have? Do you just want to have a trial of resuscitation? So all these things are pieced together, and these are discussed with who? With the patient and the healthcare provider. They're going to discuss what they do and don't want in the event of an emergency, right? It tells all healthcare providers that, take me to the hospital, or I want to stay home. Yes, do CPR, or no, don't do it, right? And these are the medical treatments I want if I do get admitted and I get resuscitated. What do I want? Do I want to be on a feeding tube? Do I want hydration to happen, right? Does it outline who can make decisions for them? No, that is not the job of a pulsed, right? It can be on any color paper. It doesn't have to be pink. It can be any color. Any copy is valid, right? Copies should be taken with them to the hospital, so they can and brought with them, because the EMS is going to bring them to the hospital. They didn't want CPR. It's like, how do you know they didn't want CPR? It's like, it's right here. That is our legal document there, and that's really a legal document. It is legal, actually. You're actually mandated to follow it as healthcare providers, okay? Because this was done at a point when the patient wasn't under distress or under or at a point where they couldn't make decisions, right? They're able to say, hey, this is what I wanted and didn't want. Also, the last line there, you got to make sure that it follows exactly what the advanced directive says. You don't want the advanced directive to say try feeding. This one says no feeding. They should line up. All right, so this is the full pulsed there. You can see again, section A and B is looking at what do you want for CPR? Do you want CPR? Do you want the full deluxe package of medications and shocking and all these things, right? Or they can be do not resuscitate, where we're not going to do any of those things. If your heart stops or you stop breathing, we're just going to say, that's it. If your heart stops, we're going to let you go peacefully, okay? And then you might see patients in the hospital who are DNR, and oftentimes there's, they're DNR, don't do that. It's like, well, they're still alive. So we do everything up until the point their heart stops or they stop breathing. We still give them antibiotics, we still give them medications, we still give them all the things. There's a big confusion where we do say, someone says they're DNR, and someone says, they're do not treat. It's like, no, they still want those things. You can still intubate a patient who is DNR. That just means that if they were to stop breathing, you don't intubate. But if they get to the point where they might require intubation, you have to have that discussion, obviously. You don't want to leave it as a gray area. All right, and then there's comfort care on this form. The comfort care says just do everything to alleviate comfort. If you find me and you bring me to the hospital and I'm not doing great, just do comfort care. What does comfort care mean? That's like hospice care, right? It's accelerated hospice care. Give me morphine, give me anxiety medications. That's all I want. We're not going to give you Lasix. We're not going to give you beta blocker to bring down your heart rate. That is treatment, right? We just want comfort care. We just want to do anything to relieve comfort. Okay. There's nutrition here. We'll talk about nutrition coming up. And then whether you want nutrition or not, right? Because if you give someone nutrition, will they survive longer? Yes. So it doesn't make sense to give nutrition to someone who wants to die. You're going to make their death longer or prolonged. Okay. Section D is where it has to be signed. If it's not signed, you can't. If it's like half filled out, that doesn't count. It needs to be all the way filled out. All right. And it can be rescinded at any time. Anyone can rescind it. Even if there's an HPOA that was outlined in the advanced directive, they can say, no, I don't want that. Sorry, we're done. All right, I know they filled this out with their doctor and they all discussed it. They probably had like a 30-minute conversation, but no, we're not doing that. So that it can be rescinded at any time. All right, so a healthcare surrogate. So a surrogate is someone who makes healthcare decisions for the patient when they can't. And this outlines in California what happens if there was no HPOA, right? There was no advance directive filled out. And what do you do for the patient? Who's going to make decisions? Because grandma's there, grandpa's there, aunt's there, sister's there, daughter's there, son's there, father's there, mom's there, the next door neighbor's there. Who makes decisions for the patient? Well, what if the next door neighbor is the one that took them to all their appointments and had discussions all the time about what they wanted, and they've never talked to their family in 10 years? It is going to be the next door neighbor, right? It's the person who knows the patient the best is the one that makes the discussion, makes the decision points for them. Okay, so there's that piece. I mean, that can get a little gray area. Usually, though, in California, we're definitely going to find who's going to be the first one to make decisions for them. And the first person to make decisions for a patient when they can't for themselves is the spouse, right? So the patient's spouse is always the first person to make decisions. What if the spouse is divorced? No, you got divorced. You're legally separated. You cannot legally make decisions anymore for your spouse, right? So if they are legally married, they can make decisions, right? There's the whole thing, but that's why it's like I don't know, mom and dad are still alive, but it's the spouse, like they're in a homosexual relationship. The spouse is like, why can't I make decisions for my husband? That doesn't make any sense, right? No, it has to go to the mom. Sorry. So that's why there's another piece there as far as legally who makes decisions for someone when they're in a point where they can't make decisions for themselves. Okay, but what if the spouse isn't around? Well, there is no spouse. They never got married, or they get married and they had kids and they got divorced, right? So it's going to be the oldest kid. Right? So there's 5 kids. It's the one who's the oldest. What if you have fraternal twins? No, we're going to say, no, that's the oldest person. All right, we're not going to get complicated. All right, so that's first, second place. Third place is parents, right? Parents make the next decision. So first place is the spouse. Next place is the kids, their bloodline, right? The third place is going to be the parents. Fourth place, last place is siblings, okay? And if none of those can make decisions, or they've never seen the patient in 10 years, they said, do whatever you want, I don't care, keep them full code, I'll be there in 3 weeks. So then it could go to someone who's the closest available person, right? It can be the next door neighbor, if needed be, okay? It's the one who knows the patient's wishes the best. That's the one that should be making the decision points. Okay, so the last 2 domains the last few ones are spiritual things. So what do we want? How do we want to support someone's spiritual guidance towards end of life? What questions might they have? And they might not all follow the same practices that other ones in the same faith might, right? So we want to make sure we're asking questions, be supportive, encourage open discussion over what they want towards the end of life, right? And then domain 6, so that is the cultural aspects. So certain cultures want everything done, meaning that they do not want to give up on life. They want to say, well, God gave us all this life and gave us all these things, then we want to do everything that God did. Well, what if, some of these things are natural and some of these things are unnatural? A lot of these machines are developed, a lot of these things can keep people alive, and that is, unnatural. God has already said, well, I'm taking you back. It is your time, but then we are keeping them on Earth with these machines. And there's the argument, well, God made the machines. So it's a whole thing, all right? But you still want to support what their points are, and you want to discuss where they're coming from, and figure out what is important to them, and if they can if they're going to have a good quality of life outside of their diagnosis, outside of their disease progression. Okay, so family support is making sure they know what the plans are for the patient and what the patient wants. Make sure everybody's on board, right? Oftentimes you have families that are huge, and then all the families come in and say, "Why did you do anything?" Like, we already had this discussion. Let's talk about what was discussed between the power of attorney and the patient, and let's have this discussion. So it's difficult to get everybody on the same page, but we make an attempt to do that, right? Allow family to communicate their concerns, encourage them to participate in care if possible. Brushing hair, make sure the mouth is moist, lip balm, etc. Communicate with the family, listening to their concerns, right? And say, oh, I'm not going to see them again. This is going to be really hard. I don't know what to do next. You have to support those things. And then identify the site of where they may pass away. Do they want to be put on hospice and transferred home? Do they want to continue all care up to the point where their heart stops in the hospital setting? Or are we going to give them 3 days of that, or 5 days of that, or 2 months, 3 weeks? So we have to consider and discuss these things. And we have to take care of the family too, and they have to take care of themselves. There's a lot of caregiver burnout because of, they say, I forget, it's on the pink slide there, it had how much caregiver burnout there is when they develop chronic disease in themselves because of how burnt out they get, right? The amount of stress and unhealthy eating and such they get can lead to their deterioration too. So you want both parties to be as happy as possible. And during COVID, our communication with the family was via Zoom. That was our best thing we could do, is to support them for the first 20 days via a conversation via Zoom. And sometimes they didn't get to even see their loved ones pass away because it was the nurse in the room that had to plan that out, right? All right, so our last domain is the palliative care, where we're actually caring for the dead patient, or dying patient, I should say. So the dying patient is going to have certain symptoms that we have to think about. So they're going to have pain, so we have to fix the pain. How do you fix pain? With opiates, right? But opiates, all opiates, every sedation medication ever causes what side effect? Respiratory depression. What else? Bradycardia, maybe, but what else? Decreased LOC, shouldn't travel with high machinery. What else? Hypotension, so low blood pressure. If you didn't say, I'm sorry, I didn't hear you. So you have really high pain, but your blood pressure is 90/30. Do you give the morphine? Do you give the pain medication? You do. If they are dying, they are DNR, they are comfort care. I should say it should be comfort care at this point. If they are comfort care and they are dying patient, you give pain medications, right? It's called double effect. So yes, the morphine may kill them, but the morphine is for pain, right? The morphine may drop their blood pressure, but the morphine's for pain. The morphine actually also relieves the feeling of shortness of breath. So if you have a CHF patient at the end stage and they're drowning, right? It relieves that sensation of drowning. Okay, so pain, discomfort needs to be addressed. Usually we give morphine like every 1 to 2 hours. We're given very, very frequently so we can control their pain. And like the blood pressure might be like 40/20. Do I give the morphine? Yes, it's for their pain. Okay, so we can't. Of course, you have to have a pain score. And then there's non-pharmacological things you can introduce. They can do acupressure. They can do essential oils. You encourage all those cultural things. No burning incense or anything fancy, but they could be doing things in the room to help support not really the patient now, but now the family's grief. Okay, and we take away oxygen. So what does oxygen do? It makes you live. The patient wants to die. So do you give oxygen to make them live? No. So you take away oxygen. So if they're on a non-rebreather mask and they're like, you give me some pain, I'm in pain, and you're going to say, okay, I'm going to give you your pain meds, and we're going to take away the oxygen mask, right? Sometimes families might request it, but we're saying the best thing to do, the most evidence, is that you take away the oxygen, right? And why is that? Well, it's a barrier of plastic between the patient and the family, right? So the family can actually visit and kiss and do things and support their dying loved one. Okay, so you take away oxygen when it's a dying patient, when it's a comfort care patient that's hospice and end of life. And then respiratory distress. So we mentioned morphine is great for that. Morphine is going to remove the shortness of breath sensation. These guys will get dyspneic, tachypneic, accessory muscle use. We can elevate the head of the bed. That can work. Do we provide oxygen? No, do not give oxygen. And oxygen might be comforting to the patients, but we don't. It's all these wires and stuff in the way can get in the way. We want to take everything off that we can. All right. Opiates are going to inhibit that sensation of shortness of breath. They can also have what's called a death rattle, and it's where they are, they're trying to talk and they have this really, really thick mucus at the back of their throat, and they have all or if they're breathing, they're not alert. They have this, every time they breathe, it's making a lot of noise. That can be very, very disconcerting for the families, so we want to make sure we prep them, know that this might happen, and we have medications for it. We have medications that can dry up the secretions in their lungs, in their oral airways. What are those medications called? So glycopyrrolate and scopolamine are 2 medications, okay, that we can use to dry up those secretions. And then what if they have secretions? Should we suction them out? You can suction them, but you shouldn't suction like routinely, like suction, 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 suction. It's going to cause a lot more secretions to build up. Okay, and then nutrition and hydration. So same token, does nutrition make you live longer? Yes, this person has chosen to die, so they should be allowed to die. If we give nutrition, that's going to make them die in the future, not when they should, right? Also, when you don't have nutrition, you start forming ketones, and ketones are actually euphoric and make you feel and remove the sensation of hunger, okay? And it's going to, also if you give feeding to someone, they can then aspirate, and now they choked to death instead of dying of just their natural disease process. And then hydration, same token. So fluids are going to make someone stick around for longer. So we want to take away fluids, take away hydration, take away nutrition, take away oxygen, and that's going to make the patient die, because that is what they have chosen. Right? They've chosen to die, so we have to support that. We do not support that if we give them nutrition or hydration or oxygen. Okay. So what else? So remove nutrition and hydration. They may get delirious, so we have to support them through that. They may get anxious. We have anxiety meds we can give. Okay. If they have like a fever, we can give fever reducing meds like Tylenol and such. But we want to make sure that we are, supporting their physiological functions as much as possible. All right, relieving comfort. Okay, so post-mortem care after they have died, what do you do? So the next things are to, of course, let the family know what the next steps are. We have like booklets at both hospitals that let them know all the different financial things they have to do. They have to go to the Social Security office. There's all kinds of extra steps afterwards. But what do we have to do? We're going to make sure we're going to wash them. We're going to grab some different items to get a shroud to cover them up. We're going to put the tags in the toe, just like in the movies. We're going to make sure they are clean. Again, treat them with respect. The family can be present if they want to be present. There's certain things they might want and culturally to happen at the end of life. Remove all the lines and tubes. Sometimes they're a coroner's case. A coroner's case means they had a unexpected death. They had like an overdose. They had a sign of they had exposure out in the elements. They had a procedure in the hospital and they died from that procedure within 24 hours. There's certain things that make it a coroner's case where we would keep the tubes and lines in. But otherwise, you take everything out and you return them back the way you found them. Basically, they came in this way. You're going to return them back that way as well. Okay, and to explain the expected changes with a dying patient to the family. We are going to lay them flat. We're no longer going to raise the head of the bed. Otherwise, we're going to be like that for 2 to 3 days. Right? That's called rigor mortis. Right? So we want to make sure we lay them flat after they've died. And they are going to, they might have like pooling in the extremities that we can discuss with the family. You might see that. Usually we don't let the family be there for more than 2 to 4 hours. It depends on hospital policy. But usually after 2 to 4 hours, the family has to leave and we bring the body down to the morgue, right? Where they will then be picked up and brought to a mortuary. Okay, so rigor mortis can happen. There's liver mortis, which we talked about with our dopamine meds, right? Our dopamine agonists, sorry. Those guys can cause this like lacy-like appearance on the skin, where it looks like they have a dead skin, dead extremities. Okay, so we have like 3 more slides. We'll kind of muscle through this last 3. Yes.
Quick question. So for the coroner's case, how do we know that it's the coroner's case?
So there's a Form 18 for LA County. So LA County has comes from the coroner, and on the back of that form, it tells you all the criteria. It tells you those things. It says like a therapeutic misadventure, which means you gave too much normal saline, right? Or you gave you had a exposure. They had an overdose. They were a trauma patient. They got in a car accident, for instance, right? So yeah, and then there's checklists at both hospitals that will tell you what to do at the end of life. And then we also call the organ donation companies as well, and they chime in as well. Okay. All right. So ethical, legal. Make sure the decision maker has been assigned, that we have all these things in place to know what to do at the end of life, right? And there's something called the Natural Death Act in California. Other states have this as well, which is the patient's right to die. So it's their decision to say, hey, I'm done. I want to die. That's my prerogative. I should have that right. And we granted that right in the late 70s, right? So for instance, if you have a terminal illness, it's like they should have the ability to decide what to do end of life, right? So like over here is a patient with, I think, kidney disease. And at first we'd had the goals of care conversations. Hey, what do you want to do? I want to live longer. I want to have some comfort. I want to make sure that I'm independent with my ADLs. And then she started getting worse and worse and worse. And then we say, you know what, let's have another goals of care conversation. You've been hospitalized 3 to 4 times. Your kidney disease is getting worse. What do you want to do? Well, now her priorities change. She wants comfort. That's what I want. And then I want my independence, right? My ability to do have a quality of life, and then longevity. I want those things over just living longer, right? It's quality over quantity. Okay. So what do you do when the patient is comfort care? Is like you mentioned just prior, and how do you promote the dying process, like you mentioned with oxygen or nutrition or hydration, and a lot of things go to court to decide like, oh, they're so mean to take away the hydration, but they have a terminal diagnosis and they wanted to die, so that is that we have to respect that their wishes. Okay. And what if a disease is incurable and the patient's of sound mind and they want to die? They want to withdraw care. Not withdraw care, but they want to just take a pill and die. Can we allow that? And yes, you can. That's called physician-assisted suicide or medical assistance in dying. Okay, so medical assistance in dying. So we provide that to them. We say, hey, this is you have a critical illness, or you have a long-term illness, and you're not getting better. And what do these are our options. And in California, it's an option. In our capital of the U.S. in Washington D.C., it's an option. So it's a lot of there's a lot of debate over this. There's a lot of little politics that come into play, but it is legal in California, so we have to discuss it. Right? So there's physician-assisted suicide, and there is euthanasia. So euthanasia is where you say, you know what, let me start an IV on you, and let's kill you. That is euthanasia. Or you determine to say, hey, you look like you're suffering. Are you suffering? Let's have a conversation. Come with me. All right. And you have like a long walk. You have this coercion that might take effect. It sounds a lot like a what's called like a cult, right? So and you all drink the Kool-Aid together, right? Or that person's still and that's called euthanasia, right? So, but this is not euthanasia. This is someone that decides that they by themselves, and they come to a provider and tell them, I'm at my end. This is what I want. I want to die, right? And there's a lot of criteria that have to be met before that happens. They have to sign paperwork. They have to wait 30 days. They have to have a cooling off period. They have to have all these things to make sure that this is right. They have to have a prognosis that is terminal too. They can't just say, you know what, I hit 40. That's it. That was my goal, right? So it has to be a terminal diagnosis. It has to have a prognosis that is poor. It has to have, they have to also be able to take the medication too. Okay, so double effect, we talked about that. And euthanasia, so it's like you're giving morphine to someone, the blood pressure is 40 over 30, 40 over 20. It's like, that's euthanasia. I'm killing them, right? I'm going to give this morphine, they're going to die. So is that euthanasia? No, that's called double effect. Double effect is where you're giving it not to kill them, you're giving it for the pain, right? They have the pain. Yes, it might result in their death, but that is okay because we are giving it for pain, okay? So that's the idea behind double effect, and that's different than euthanasia, right? Euthanasia is legal in some countries. Like Kevorkian got in trouble, but Kevorkian was the one that he was a little bit weird, that he kind of convinced a few people. So, but otherwise, he had good intentions. He had good intentions, though. But yeah, so physician-assisted suicide is the idea that we are going to provide them the ability to end their life, because it is their choice to end their life. Okay, and then what's the difference between that and suicide? What's physician-assisted suicide versus suicide? So suicide is where it's usually related to depression. It's very, very impulsive. It is a violent act, whereas this is not violent. It's usually you're surrounded by your loved ones, you take the medication, and you die in 5 to 10 minutes, right? So that's the idea behind the physician-assisted suicide. All right, so myths. There's a lot of myths about it that lawmakers reject it. They're actually for it. Their taxpayers are paying for it. The patient pays for it. It costs about $100, right? It's not a big deal. Okay. There's lethal pills that go unused and be in the hands of all the kids. That's not been documented. That's not happened, right? And if you read about it, if we just present this to you now, you're going to want to do it, and you're going to spread all the bad stuff everywhere. That's also not true. There's a lot more nuance behind it than just like, oh, it's going to make, we're just killing patients left and right. Okay, and like it's very, very impersonal. Someone just sign up on Amazon for the free health service and get it. No, you can't get it through BetterHelp. That's something for suicide, not physician-assisted suicide, right? So they're going to, they go to their doctor, and it's a whole process. Okay, this is the process here in California, right? They get the diagnosis that it's terminal, right? They have a second provider needs to make that decision. It can't just be one person because they could have made a mistake, right? So they say, you know, yes, you do have this terminal cancer. You do this. I see this here on this CT scan as well. I read it. This shows that it's inoperable. So yes, you do have a terminal diagnosis, and they say, okay, well. They say, well, I want to end it. So they say, well, first we got to make sure that your mental status is okay. We have to make sure that we have to get 2 verbal requests 15 days apart. We have to have 2 witnesses sign that, so it's not coercion that someone that they went to the doctor and they came out and they say they want to kill themselves. Well, what is going on here? What are they saying there? So it has to be witnessed. It has to be, you know, we go through all the different processes to make sure that is legitimate. And then we finally get the medication, and they have to take it on their own. Again, it costs about $100 for the medication. It's a barbiturate, right? It's barbiturates just shut off the brain, right? And if you shut off the brain and you're not breathing, that's going to cause death, right? So eligibility, again, they're 18 or older. Like in the previous slide, I think in Colombia, I think they had to be 6. I was like, that's a little bit low. And like because Canada's like 12. So there's different opinions on when it should happen, but mentally competent and have a terminal illness with less than 6 months to live. And again, there's 2 licensed physicians. They get a mental health check. They have to make sure that it is requested twice, more than 15 days apart. They have to have a witness sign it off. It's a whole process, right? It's not all of a sudden. Okay, so that's the idea behind physician-assisted suicide. And cancer is usually the number 1 request. They have a malignant tumor of some sort. They have ALS and they have MS. And obviously the ALS person has to be able to take the pill of their own accord. So that's the point. If it's after that point, you can't administer it via someone's G-tube and say, oh, now we're giving this medication for assisted suicide. That's where they would go to these other places where they have euthanasia, right? Like Sweden has euthanasia. I forget Canada's, but they have euthanasia in other places where someone with ALS can seek this out. All right, that is the end of life.